Hello, everyone. Welcome to our Zoom meeting. Today, we're going to discuss different topics, and the Brown team will be presenting some of these topics. So, Dr. Amal will be leading the Zoom meeting. Dr. Amal, when you are ready, please go ahead, and Dr. Saja will be the first speaker. Thank you, Dr. Amal. Thank you, Dr. Saja, and thank you, everyone, for attending.
Hello, everyone. Thank you so much for attending our meeting today. So let's start by listing our agenda for today. So the first topic is going to be about sleep issues in older adults. Should be there are no presenters assigned, but this is going to be the first topic. The second topic is going to be using Zotero for reference management, and it will be presented by Dr. Hajar. Third topic is going to be about how to prepare for a webinar, and it's going to be presented by Dr. Sahar. And then we are going to move to the mock interview session, and we will have some volunteers who are going to be presenting this. Also, our last topic is going to be about how to start a nonprofit organization by Dr. Saja. And then the last part is going to be about project updates. Dr. Saja, if you are ready, please go ahead. We're going to start with you.
Sure. Thank you so much, Doctor. And I appreciate you. Thank you so much, Dr. Nader, for everything, as always. I'm going to start by sharing my screen. I don't know if you guys can see.
Yes.
Okay, perfect. So now we're going to talk about how to start a nonprofit organization, a step-by-step guideline. So first, before I talk about the whole process, I'd like to share my personal experience with it. Just a second, please. I had the pleasure of be a co-founder of the nonprofit organization back in 2017. The name was International Medical Graduate for Texas. That happened when the Hurricane Harvey struck Houston 2017, and it was founded by Gaith Ibrahim. Now he's in I think he's a specialist right now. Back in the day, we were studying together, and that organization was its main goal was to aid in the Hurricane Harvey recovery and to empower IMGs and their role to serve our community. Of course, what we did at the NRG Shelter Clinic, which is a big stadium in Houston, IMG for Texas served almost 2,500 residents, treating 1,400 patients through 284 hours of clinical volunteering by 34 international medical graduates. We were holding shifts. We were assisting with the triaging area. They set an emergency room there, and we were helping them triaging the patient and sometimes treating, writing prescription under the supervision of Harris County doctors, of course. My role was as a team leader of that organization. I played a pivotal role in organizing blood donation campaign. I collaborated with MD Anderson, and they were very happy that we went and donate. Unfortunately, I didn't donate at that day because my blood hemoglobin was low, but I still got the T-shirt, thank God. But yeah, so we rallied our IMG members to donate, and they were, we went together to MD Anderson Donation Center, and I coordinate their transportation. I use my car, to be honest, back and forth. And the other thing that we did, as I mentioned earlier, in the NRG Stadium, it was like a big, huge stadium that most of displaced family lived there. And of course, most of them had some medical issue, and we helped with the triage area, as I mentioned before. Additionally, I was responsible for arranging mostly all of the organization's events, meetings, logistics, ensuring our effort were impactful and well executed. Now we're gonna we're gonna have a broad introduction about what a nonprofit organization is, and throughout the presentation, we'll get you steps that into how to start one if you're interested in one, or how to join one, and you have more general perspective about it. Like we all hear about nonprofit or profit or whatever. So I hope by the end of this presentation, you'll have a good idea about what nonprofit organization means. We're going to start by just introducing it. It's a nonprofit organization. That means it's an entity designed to operate for the collective public or social benefits rather than the profits of the owners or shareholders. It focuses on advancing a mission rather than generating income or for personal gain. Such organizations are typically exempt from paying federal income taxes under the IRS Section 501(c)(3, enabling them to allocate more resources towards achieving their goals and supporting their causes. Just to talk about the type of tax exemption status, we have two as of under that law. 501(c)(3 is the most common type for charitable nonprofits, offers tax exemption and for the organization, of course, and tax deductible donation for contributors. For example, when you apply, let's say it's the tax season and you applying, to do your tax, and you say like, hey, I gave 100, and of course you're gonna get a receipt for that. 100 to Goodwill, 100 to this other organization, 200 for that. So you get a receipt and you get a deductible. So it's not only gonna help the organization, it's gonna help the person who donate as well, because that will be, they will return it back to him as a tax deductible. The other 501(c) designations, there are types of tax exempt organizations, such as 501(c)(4 for social welfare organization, 501(c)(6 for trade associations, and more. Each has specific qualification and benefits, but what the most important one for us is the first one, which is 501(c), which is going to be using it to start for our nonprofit. In order to start a nonprofit organization, it involves steps, of course, just like any other projects, you have to create steps and, be organized and start to see how you're gonna succeed in that. Just like any other things, it's good to plan ahead. And we're gonna start with step one. Step one involve define your mission and vision. So begin by crafting a clear mission statement that explains your nonprofit's purpose and vision statement that outlines the long-term impact you aim to achieve. This step is critical as it guides decision-making and helps attract donors and volunteers by providing clarity and focus. It's very important to define your mission and goal, because if you're passionate enough, you can, reach to a bigger audience that can help you. Either they are in the same boat as you are, or donors that can help you and believe in your cause. Moving on to step number 2, conduct market research. Identify a gap your nonprofit can fill by researching similar organizations. There's so many nonprofit organizations out there. How can you stand, as a startup organization? Defining your target audience, that's very important. That's example, IMGs, like what we're doing right now. We need to target IMGs, and there are so many of them. They have no idea how powerful they are if they come together to help the United States health system by coming together and do some activities, and they will see your role grow day after day, and that will help us eventually get into residency. And of course, it's not only the main role. The main role is to help and, and provide service. Because I think most of us went to medical school and went to healthcare because we genuinely love to help other people. Step number 3 is develop a business plan. Create a business plan that includes an executive summary, organizational structure, financial plan, and fundraising strategies. This is crucial for guiding your nonprofit's growth and operations effectively. Step 4, incorporate your nonprofit. Choose a unique name that reflects your mission. Register your organization in your state for legal recognition and draft bylaws that will govern the operation and structure of your nonprofit. Step number 5, we already talked a little bit about tax exemption, but here it's very important. After you finish all the steps above, you need to obtain a tax exemption status by completing IRS form 1023 or 1023-EZ and submit details about your nonprofit's mission, financial, and governance. Achieving this status allows donation to be tax deductible and exempts your organization from federal tax. Again, this is very important. Just like I mentioned before, not only you're going to be exempt from the federal taxes, so the resources will stay in your hand, and you can, use the resources towards improving your organization, but the person who donates can get a tax deductible, which is going to be win-win for the person and for you. Step number 6, build your board of directors. The board governs the organization, ensures financial accountability, and provides strategic directions. Select members with diverse skills and strong passion for your mission to support the nonprofit's growth. I can give you an example for that. If you know of a lawyer, let's say, or we have so many IMGs that they've not they have an different interest in different fields. They can be very helpful in terms of diversity in your organization. If you have a person, a friend, and just like I mentioned, a lawyer, it helps with the law making, sorry. And if you have a person good with social media, it can help you focus on that area, and etc. Number 7, fundraising and sustainability. Of course, you need some money to support that organization. As we mentioned, it's a nonprofit, so you don't have something that you can sell or money. You can definitely contribute yourself, but it's important that you have a raising event, or explore diverse fundraising options like grants, like reaching out to universities. Individual donation is always welcome, of course, if they believe in your cause and you targeted the right person. Corporate sponsorship, which is always good, and events or crowdfunding. Develop a sustainable financial strategies to ensure the long-term success of your nonprofit. And all of that goes back to building your board of directors. If you have a good board of directors, one of them assigned to do that. So instead of losing or resources, you can one of the team can be focusing on that, or two can be focusing on that, which is very helpful, of course, in the long run. Step number 8, we have marketing and community outreach. That means develop consistent branding, utilize social media and events to spread awareness. Recruit volunteers to support and advance your nonprofit's mission. Again, it's very important to do that outreach to the community and outside the community as well. Not only IMG, I'll give example like IMG. Nonprofit for IMG. Not only IMG are targeted, maybe other people are interested in healthcare, non-IMG US resident, or people who were in our shoes. they are interested and they can help. Some of them, or most of them, they were, you know, they wanted that to happen because at their time, when I talked to people, they said no one helped us this and this, no one did that to us. So I feel like the circle needs to end at some point, and somebody needs to step up and help. And that's what Dr. Nader is doing with telegeriatric research fellowship. He's empowering us to reach our potential, to help us eventually match, or, you know, help us with all of that. So we extend that thank you to Dr. Nader, of course. Step 9, compliance and reporting. Of course, after now you had like your nonprofit organization, it's kind of established with the paperwork and everything. You had your board of directors, you're doing everything that you're supposed to do. Now you submit your IRS form 990 and other state filing annually. Maintain a detailed records for finance and operations to ensure transparency, of course, by providing key information to donors and stakeholders. For both sides, you keep a complete records, of course, for a person or organization that helped, whether financially or whether with resources. All of that can be, you know, kept as resources to protect you and the organization integrity. In conclusion, starting a nonprofit is a fulfilling endeavor, but it demands thorough planning and commitment. So you have to stay focused on your mission, remain adaptable to changes, and continue evolving as your organization grows to maximize its impact, sorry. So I came up with a new project. The organization name, I named it International Medical Graduates of America. The mission statement that I came up with, IMG of America is an organization. Of course, now it's an organization. I start filing for the the right paperwork, but because I'm moving from state to state, so I'm waiting until I go to Michigan, and from there we'll refile the correct paperwork to the area that I'm going to be residing. So again, it's this organization dedicated to assisting unmatched international medical graduates in the States. The goal is to provide resources, mentorship, advocacy, opportunity to help IMG integrate into US healthcare system. And to be honest, just talk to each other, you know, lift each other's spirit. Just like sometimes a nice word will be very helpful to a person going through this journey, because it's a very tiring and you know, it's a hard journey, and it's always nice to have a community to support you. Our vision statement is to create community where all international medical graduates are supported, valued, and integrated into the system, contributing to the diversity and excellence of patient care. And of course, most, if not all of our IMGs are capable of doing that. They just need an opportunity. If anybody interested, I do have the link. I can share it after Dr. Nader's approval to the group when we're done. Thank you so much for listening. And please, if you have any question, don't hesitate to ask me. Thank you so much.
Thank you very much for the great presentation, Dr. Saja.
Welcome.
Please, if you have any questions, you can ask Dr. Saja. That was a great presentation.
Thank you, dear. Appreciate you.
Okay, so if there are no questions, we are going to move to the next topic, which is sleep disorders in the elderly, and I'm going to be presenting that topic. I'll start by sharing my screen. Can you see my screen?
Yes, we can.
Okay, great. So my name is Dr. Amal, and I'm going to speak about sleep disorders in the elderly. So let's start by the first slide. Sleep is associated with well-being, health, and mortality. And sleep is a vital physiological process with important restorative functions that are essential for optimal daytime functioning. Let's start by a background. By 2025, 62 million Americans will be over the age of 65. So the population is aging. Annual direct costs associated with insomnia are estimated to be about $15.4 billion. That shows us the impact of insomnia on the economic and on the population in general. So sleep disorders there are many sleep disorders. So we are going to start with insomnia, which is the most common one. Insomnia is defined as difficulty initiating sleep, maintaining sleep, or unrestorative sleep leading to daytime impairments. It affects about 20 to 50% in Western countries' adult population, so it's a very common disorder, reported more in elderly women than men, and up to 57% of non-institutionalized elderly have problems with chronic insomnia. So normal sleep is affected by many factors, including significant distress, such as impairments in occupational or other important areas of functioning or social processes. So one of the theories for insomnia and how insomnia develops is that total sleep time may not necessarily decrease with age, but the way in which sleep is consolidated becomes altered, and one study showed that healthy elderly persons were less sleepy and performed better in tests of alertness and attention than young subjects after sleep deprivation. A new vital sign. So sleep disturbances affect not only nighttime sleep quality, but are also a risk factor for daytime sleepiness, which may negatively affect participation in physical exercise and ultimately functional ability. So this shows us that insomnia has impact on the functional ability of the person, and that's why it should be treated. Screening for sleep disorders as a new vital sign, as sleepiness is emerging as an important aspect of health promotion and disease prevention, as insomnia is linked to chronic diseases, as we are going to see in the subsequent slides. So what is a chronic insomnia associated with? So chronic insomnia is associated with a wide range of health problems, including mental disorders, discomfort, anxiety, and substance abuse. Chronic insomnia can increase risk for new onset depression, with persons with persistent insomnia 3 more likely to develop depression within a 1-year period, so it's strongly associated with depression. The possible causality between short sleep duration and development of diabetes mellitus in community dueling middle and older age adults. Evidence-based on how to manage insomnia. Sorry for that. So benzodiazepines and non-benzodiazepines are effective in the management of chronic insomnia. However, benzodiazepines and non-benzodiazepines and antidepressants pose a risk of harm. So as you might know that benzodiazepines are one of the drugs that we shouldn't be prescribing in the elderly according to the various criteria. So they are not recommended. And benzodiazepines have a greater risk of harm than non-benzodiazepines. Melatonin is effective in the management of chronic insomnia and subsets of the chronic insomnia population, and there is no evidence that melatonin poses a risk of harm based on a small number of studies. Chronic insomnia is associated with older age. Relaxation therapy and cognitive behavioral therapy are effective in the management of chronic insomnia and subsets of the chronic insomnia population. So there are many modalities on how to manage insomnia. Some of these are can be treated with medications, and some can be treated like with conservative measures. Let's talk about normal sleep. So the circadian rhythm, the 24-hour dark light cycle, needs to be activated for sleep by entry of light via the eye. As you might know from the normal physiology of sleep, that the pineal gland is the gland that is responsible for receiving the light, and then it modulates the secretion of melatonin according to the perception of light. So the light-dark cycle is very important in the normal physiology of sleep, and that's why it's advised that the room should be dark. This will help with better sleep. Increased daylight exposure and physical activity may help normalize circadian rhythm and the circadian rest activity rhythm. What are the benefits of physical activity? Physical activity not only helps with normal sleep, but it also decreases the risk of cardiovascular disease and osteoporosis and decreasing blood pressure. It also increases glucose tolerance and insulin responsiveness, so decreases insulin resistance and the risk of type 2 diabetes mellitus. It increases mental acuity, and this makes sense because sleep is very important for mental performance, and also it helps with psychological well-being. Sleep architecture. Normal sleep progresses through several stages in a predictable pattern. So there are two main stages or two main components of sleep. The first one is the non-REM sleep, and the second one is the REM sleep, and we spend most of the time on the non-REM sleep. REM sleep constitutes a small portion of that cycle. So the non-REM sleep passes through many stages. There is the stage 1 and stage 2. So stage 1 is the transition stage between wakefulness and sleepiness. And so it's a light sleep. There is reduced brain wave activity in this stage. There is slow eye movement. And the stage 2, there is muscle relaxation. Non-REM sleep, there is decreased body temperature as well. The brain is awake and alert, so muscle relatively tense. It's not paralyzed, as you can see in the REM sleep. The muscle is still moving or still active in the non-REM sleep stage. So it's also characterized by reduced heart rate and sleep spindles on EEG and K complexes as well. Stages 3 and 4 of the non-REM sleep are the deep sleep stages. It's characterized by slow waves on EEG, slow waves with a high voltage, and low frequency brain waves. So it's a restorative sleep. Moving to the REM sleep, there is rapid eye movement, and it's the stage of sleep where dreaming occurs. There is increased brain activity, but the muscles are paralyzed in this stage. There is increased heart rate, increased respiratory rate, and active inhibition of voluntary muscles. So in infancy, sleep duration is at a lifetime maximum. It reaches about 16 hours of sleep a day, because at this stage of life, the brain is developing, and that's why they need more hours of sleep. Adults require 7 to 8 hours of sleep in 24 hours. Some evidence shows that sleep duration further decreases from young adulthood into the older years, but this is controversial. So let's move to the next slide. Meta-analysis of 65 studies of healthy adults showed men are more affected by aging than women, with a decreased total sleep time, decreased percent of the N3 which is the deep stage of sleep, and REM sleep, and increased percent of the N2 and wake time after sleep onset. So in total, the sleep duration is shortened. Women with increased sleep latency compared to men, also with shorter and poorer sleep. And sleep latency is the time it takes to enter into the first stage of of sleep. So it's increased. So it takes longer time for women to sleep as they age. Women used hypotonics at a greater frequency than men. Age-related changes in sleep architecture. Yeah, we talked about that. So let's move to the next slide. So predictable age-related changes in sleep architecture. So these are the physiological changes that occur with age. It includes sleep fragmentation, reduced sleep efficiency, decreased quality of sleep, and decreased in amplitude of low frequency delta on EEG. True sleep disorders are rare in healthy older adults. Elderly with poor sleep often have comorbidities. When controlled for comorbidity changes in sleep quality, high rates of insomnia become less. Elderly persons with insomnia often display poor sleep maintenance rather than problems with sleep initiation. So it's characterized by early awakenings. Sleep and aging, nocturnal secretion of endogenous melatonin gradually decreases with age. In every decade, except for age 30 to 39, the prevalence of insomnia is increased in women, with prevalence of insomnia being 40% in women. So in general, women are more affected by sleep disorders as they age. Let's talk about sleep patterns and aging. It's not clear whether the need to sleep decreases with age, although this is a common belief. During the late decades of life, sleep evolves even further. Ability to sleep decreases with age, and older adults report waking up earlier, increased sleep onset latency, and increased time spent in bed, increased nighttime awakening, and increased napping and decreased total sleep. Here, some elderly report sleeping more than younger adults and report a more consistent sleep pattern. A meta-analysis of 3,577 healthy subjects showed that total amount of sleep decreases linearly with age at a loss of about 10 minutes per decade up to the age of 60. The percent of REM sleep also diminishes but plateaus after age 60. So sleep efficiency declines secondary to sleep. Latency arousals from sleep and time awake after sleep onset. Acetylcholine may play an active role in maintaining normal sleep hygiene. So what are the variables associated with poor sleep quality? There are many variables that are associated with poor sleep quality, and these include gender, marital status, chronic illness, presence of psychological stress, level of daily hassles, stress, level of social support, dietary habits, excessive daytime napping, medical conditions, loss of spouse, depression, retirement, social isolation, comorbid disease, also visual hearing impairment. So increase isolation and modify the circadian rhythm. This is what's the mechanism by how like visual and hearing impairment can affect sleep. In one study, these factors were found more protective. So during hospitalization, the prevalence of sleep deprivation seems to increase for multiple reasons, including environmental factors, circadian dysregulation, and acute clinical problems. These complaints of insomnia can persist for several months post-discharge. Healthy people, this is a 2010 study, showed a relationship between sleep disturbances, daytime sleepiness, exercise, and physical function in community-dwelling older adults. The findings suggested that in healthy older adults, sleep quality and daytime function were normally maintained. The aging process could not explain a decrease in physical activity. Also, increased age did not correlate with sleep disturbances in this study. Sleep time decreased in men. Sleep time decreased on average of 27 minutes per decade from midlife until the 8th decade, and an association between the need for institutionalization and the presence of insomnia has been demonstrated in healthy males. So many factors that impair sleep in older adults can be diagnosed and treated. And true sleep disorders are rare in healthy older adults, and elderly with poor sleep often have comorbidities. So the physiological changes that occur with age are not considered to be a sleep disorder, and a true sleep disorder usually occurs in elderly who have comorbid conditions. So in older patients, continuously decreased sleep homeostasis may contribute to the inability to maintain long sleep episodes, irregular meal times, decreased bright light exposure, nocturia, and increased mobility and decreased exercise. 50% of men and 70% of women over the age of 75 have no regular physical activity. And during the late decades of life, sleep evolves even further. Elderly persons with insomnia often display poor sleep maintenance rather than problems with sleep initiation. Insomnia is stable in middle years and abruptly jumps in decades 70 to 79 and 80 to 89. Moving to the next slide, elderly spend more time in lighter stages of sleep. So these stages are characterized by decreased slow wave sleep, increased fragmentations of entire sleep cycle. REM sleep may decrease overall, and it takes longer to initiate sleep. There is also decreased total sleep time and have early morning awakenings, increased need to nap during the day, tends to fall asleep during the daytime faster, and elderly women maintain sleep better with aging, but with menopause have increased subjective complaints of insomnia. Optical changes in the eye, like senile miosis and increased crystalline lens opacity, as we said earlier, decreases light reaching the retina and affects circadian rhythm. So let's move into how we can evaluate sleep disorders. We are going to start by taking a detailed history, and it's usually a multidisciplinary approach. And we are going to ask about past sleep history and detailed inventory of specific sleep complaints in the presence of bed partner, inquiry regarding alcohol, tobacco, caffeine, and other meds. It's very important to ask about medications, especially in the elderly. And we are going maybe in subset of patients to perform a hypnogram. It displays a distribution of sleep stages across the night. Healthy adults' sleep pattern includes starting with the non-REM sleep, which constitutes of the stage 1, 2, 3, and 4, followed by a period of the REM sleep. So REM sleep occurs every 90 minutes. Reduction in N3 and increase in REM as night progresses. So we are talking about the normal sleep in this slide. Punctuated by brief arousals and awakenings. So this slide summarizes the normal sleep pattern. Examples of sleep-related questions that can help to screen for sleep problems in the geriatric patient. So these questions are for screening purposes. The first question is asking about having any difficulties falling asleep or maintaining sleep. Also, another question we ask patients is, do you feel excessively sleepy, tired, or fatigued during the day? And what's your sleep schedule during the weekdays and on weekends? How many hours do you sleep during the night? How long does it take you to fall asleep after deciding to go to sleep? So this tests or asks specifically about the sleep latency period. As we said, it's usually increased, especially in elderly women. How many times do you wake up during a typical night? And also, this tests like fragmentation of sleep. Do you feel refreshed when you wake up in the morning? And do you have loud snoring? And do you stop breathing at night? This question specifically screens for obstructive sleep apnea, which are one of the comorbidities that can lead to insomnia. Do you have restlessness or crawling or aching sensation in your legs when trying to fall asleep? This asks about restless leg syndrome, which is one of the causes of insomnia and impairment of sleep. Do you repeatedly kick your legs during sleep? And do you act out your dreams? The last two questions asks about like sleep enactment disorders, and it's associated with mental disorders in the elderly, and it's linked with the increased risk of developing Lewy body dementia. So let's move to the labs. Polysomnography, specifically with complaints of sleep stage abnormalities, restless leg syndrome, unusual behaviors, and sleep disordered breathing. So polysomnography is one of the most important laboratory tests that we can perform to patients, and it can lead to, or we can reach to many beneficial conclusions, especially in patients who are suspected to have restless leg syndrome or unusual behaviors and disordered breathing. Also, tests include multiple sleep latency tests, and objective assessment of daytime sleepiness is one of the tests as well. Also, there is another test called Epworth Sleepiness Scale. So let's move into the primary sleep disorders. Sleep apnea is one of the common disorders. The other disorder is restless leg syndrome, which is characterized by repetitive continuous leg jerks every 20 to 40 seconds during sleep. 5 to 6% of the population is affected by this disorder, and treatments include benzodiazepines, Sinemet, dopamine agonists, opiates, and iron replacement. One study showed that sleep restriction to 4 hours per night increased blood pressure, decreased parasympathetic tone, and increased evening cortical and insulin levels, and increased appetite. So shortened sleep to 4 hours increases the risk of developing hypertension. It also increased the risk of insulin resistance, and thereby developing type 2 diabetes. Association between short sleep duration and coronary artery disease and overall increased mortality. So sleep disorders not only affect mental performance, but it can also lead to the development of development of the most common chronic conditions that we can see in the elderly population. So what are the chronic medical conditions impacting sleep? Let's start by diabetes. It increases the incidence of obstructive sleep apnea because obesity is linked to diabetes, and obesity is the main cause of obstructive sleep apnea in adults. Also, it increases the incidence of sleep disordered breathing, also autonomic neuropathy, leading to ventilatory disorders. So another condition is dementia. Dementia leads to delayed sleep induction, prolonged wake time after arousal from sleep, and increased activity during periods of wakefulness. Another phenomenon that dementia can lead to is called sundowning, and increased daytime sleepiness compared with age-matched controls as well. So another condition that can lead to sleep impairment is depression. How can depression lead to sleep impairment? By exaggerated behavioral disturbances and increases number of awakenings. It can lead also, depression is linked to chronic pain, which can impair the quality of sleep. Also, depression is known to decrease sleep time. It can lead to delayed sleep onset and increased nighttime awakenings, in addition to increase in depressive symptoms. So moving to the next chronic condition, Parkinson's disease. Parkinson's disease decreases total sleep time, and that's how it can impair sleep quality. Malignancies are known to impair sleep quality, leading, and this is because of excessive fatigue, like restlessness, insomnia, and decreased sleep efficiency and excessive sleepiness. Chronic kidney disease and incontinence. This chronic kidney disease is one of the known factors that are linked to restless leg syndrome and periodic limb movement disorder and sleep apnea. Another condition that is well known to cause sleep disorders is chronic obstructive pulmonary disease, COPD, by reduction in arterial oxygenation, decline in baseline oxygen, and more frequent in blue bloaters. Blue bloaters is referring to chronic bronchitis part of the COPD, decline in ventilatory response to hypoxia, exaggerated breath to breath variability, exaggerated increase in respiratory frequency, sleep, disordered breathing, hypopneas. Also, these all can affect oxygenation to the brain and leading to sleep disorder. Also, they are at increased risk of apneas, which is a complete cessation of respiration leading to multiple awakenings during the night and impairment of sleep quality. Possible causality between short sleep duration and development of diabetes mellitus in community dwelling middle and older age adults. So poor sleep quality or insomnia is linked to the development of diabetes. An association between the need for institutionalization and the presence of insomnia has been demonstrated in healthy elderly males. Those who used hypnotics previously for sleep had more insomnia during hospitalization. So one study found that almost half of patients over age 65 living at home were not happy with their sleep, and two-thirds of those elderly more than 65 residing in nursing homes suffer from sleep disorders. So this slide shows us like how common is sleep disorders and insomnia and the impact of these sleep disorders. Those with longer sleep latency performed worse on measures of verbal knowledge, long-term memory and fund of information, and visual spatial reasoning. So sleep disorder or impairment of sleep is strongly linked to mental disorders, including dementia and mental performance in general. So what are the medications that has negative effect on sleep? These include bronchodilators, corticosteroids, because cortisol is one of the hormones that have role in the regulation of sleep. Also, decongestants, diuretics, and stimulating antidepressants. They have stimulant effect that can impair sleep. Also, antihistamines, because they increase the risk of delirium, and don't use with narrow angle glaucoma. as we know, because it increases intraocular pressure. Let's talk about the microstructure of sleep. Age-related decrease in spontaneous K complexes and sleep spindle densities on EEG and in the number and amplitude of evoked K complexes. Interpretations: age-related alteration of thalamocortical regulatory mechanisms affecting the changes in neurobiology of the brain with advancing age. Circadian pacemaker, we are going to talk about the some of the normal physiology of sleep. We'll start by the circadian pacemaker. It's located in the suprachromatic nucleus of the hypothalamus, and it's synchronized to the 24-hour light-dark cycle. Aging leads to malfunctioning or decrease in sensitivity of the suprachromatic nucleus to environmental cues to adjust circadian rhythm to nocturnal 24-hour day-night cycle, making elders more or less tolerable to jet lag and shift work. So let's move to how to manage insomnia. We will start by evidence-based standards of care to manage insomnia. So benzodiazepines and non-benzodiazepines are effective in the management of chronic insomnia. However, benzodiazepines, non-benzodiazepines and antidepressant pose a risk of harm, especially the benzodiazepine medications, because as we said earlier, according to the Beers criteria, these are one of the medications that should be avoided in the elderly population. Benzodiazepines have a greater risk of harm than non-benzodiazepines. Melatonin is effective in the management of chronic insomnia in subsets of the chronic insomnia population, and there is no evidence that it poses a risk of harm. We talked about this slide earlier, and it summarizes the fact that sleep can be managed with behavioral modifications, which is usually going to be the first line management. And if it didn't work, we can prescribe medications, but we should try our best to avoid medications that can cause harm in the elderly, such as benzodiazepines. So let's move to physiological and behavioral treatments for insomnia. The first modality is stimulus control therapy, which is a set of instructions designed to reassociate the bedroom with sleep and reestablish a consistent sleep-wake schedule. These measures include going to bed only when sleepy, getting out of bed when unable to sleep, using the bedroom only for sleep, like no reading or watching television is allowed in the bedroom, rise at the same time every morning, and no napping. The other modality is sleep restriction therapy, which is a method to control time in bed to the actual sleep time, thereby creating mild sleep deprivation, which results in more consolidated and more efficient sleep. So the third modality is relaxation training. It's about clinical procedures aimed at reducing somatic tension, like progressive muscle relaxation and autogenic training, or intrinsic thoughts, imaginary training medication. So that are somatics, so would reduce somatic tensions that are interfering with sleep. There is also cognitive therapy, psychotherapeutic methods aimed at changing faulty beliefs and attitudes about sleep, insomnia, and the next day consequences. Other cognitive strategies are used to control intrusive thoughts at bedtime and prevent excessive monitoring of the daytime consequences of insomnia. And the last modality we have is sleep hygiene education. It's about general guidelines that are about health practices like diet, exercise, and substance use, and controlling environmental factors like light, noise, and temperature that may interfere with or promote sleep. So non-pharmacological treatments include cognitive behavioral treatment, which has been successful, and very solid data that supports sleep hygiene interventions. So as I said, these are the first line treatment options for treating insomnia in the elderly population. How to evaluate sleep quality? So difficulty initiating sleep, disruptive sleep. So these are the problems that are usually associated with insomnia or sleep. So some patients have difficulty initiating sleep. Some patients, they have they initiate sleep normally, but they have a disruptive sleep. Some patients have early morning awakenings, and some others have non-restorative sleep despite sleeping normally. And it's often associated with medical illnesses, as we said, rather than aging. And when controlled for comorbidity, changes in sleep quality and high rates of insomnia become less. So it's very important to detect any underlying comorbidity in the process of diagnosing or evaluating insomnia. Let's move into the pharmacological management of insomnia. So before moving to the pharmacological management, we are going to speak a little bit about some other non-pharmacological measures. These include a light treatment, so exposure to very bright light during the day and darkness at night can consolidate rest and activity patterns in persons with sleep disorders. So evening light exposure, effective in consolidating rest activity rhythms and help them sleep better at night. Also helps to fall asleep later and wake up later. So there is a study, would person light treatment devices be effective for reliably stimulating the circadian rhythm? Made goals for light, measured melatonin levels. What are the results? Light-induced nocturnal melatonin suppression and light-induced circadian phase shifts utilize the same retinal neural apparatus and follow similar stimulus response function. One study, bright light treatment. So this is a study about how can bright light affect sleep. So blood pressure decreased with sleep at night. Limit naps to 30 minutes in early afternoon for elderly. Timed bright light treatment. Light is regarded as the strongest cure for the synchronization and stabilization of circadian rhythms and melatonin regulation. Light may even reduce behavioral symptoms in persons with dementia. No consensus on the best time of day for administering bright light therapy for dementia and depression. And the side effects of light therapy included headache, nausea, dry eye, and dry skin. So despite recommendations against use of certain meds in the elderly, evidence suggests that treatment with inappropriate medications, unfortunately, continues. So let's talk about benzodiazepines in the elderly. It can lead to many devastating consequences. This includes prolonged sedation, increased risk of falls and fractures, postural instability, and one study showed that a 60% risk, it leads to a 60% increase in risk of hip fracture. Another study from healthy people, 2010, showed a relationship between sleep disturbances, daytime sleepiness, exercise, and physical function in community-dwelling older adults. The findings suggested that in healthy older adults, sleep quality and daytime function were normally maintained, and the aging process could not explain a decrease in physical activity, and increased age did not correlate with sleep disturbances in this study. Pharmacological benzodiazepines, hypothesis. So use of benzodiazepines is also expected to significantly be associated with 6 components of sleep quality: latency, duration, efficacy, disturbances, and daytime sleep dysfunction. Another study that shows the use of benzodiazepines was associated with poorer sleep quality, and this might be secondary to physiological tolerance mechanisms. It's also associated with longer sleep latency, lower subjective sleep quality, shorter sleep duration, higher sleep disturbance, and daytime dysfunctions. Let's move into zolpidem. Zolpidem is one of the non-benzodiazepine medications that can be used for insomnia. And if used, dose should be 5 milligrams and for a short, limited period of time. There is still a concern for or about abuse and dependency, and concern about confusion and hallucinations. So what is the link between depression and insomnia? Early morning awakening seem to most consistently related to depression over time. So depression is associated or strongly associated with early morning awakenings. So strongest predictor of future depression among those not depressed at baseline was sleep disturbance at baseline. So sleep disturbance is a strong predictor for future development of depression. Alteration in sleep architecture in depression. So depression eventually alters sleep architecture, leading to impairment of sleep quality. Depression increases the risk of poor sleep quality, and poor sleep quality is a predictor for future depressive episodes. So one study found that those getting 7 hours of sleep or less were more likely to develop a depressive disorder than those getting more than 7 hours of sleep a day. Let's move into the link between anxiety and insomnia, or how they are linked to each other. So poor sleep can be a consequence of anxiety disorders. Important symptoms of general anxiety disorder, most common among older adults. So let's talk about specific anxiety disorders. Panic attacks. So one study found that both short and long sleepers were more likely to have depression or anxiety disorders. So persons with depression spent more time in bed than non-depressed, and persons with depressive disorders and comorbid anxiety disorder reported a substantially shorter total sleep time than other elderly persons. Poor sleep quality is reported in 40 to 90% of patients with depression. And insomnia or poor sleep quality is one of the major criteria that we ask about when we want to screen for depression, not only in the elderly, but in all age groups. So let's speak about insomnia and dementia. So most frequent cause of insomnia in demented patients is a medical condition or side effect of a medication. So sundowning, what is sundowning? It's a marked increase in agitation, confusion, and wandering in late afternoon or evening. How to treat sundowning? By stimulating the circadian rhythm, which a circadian system, which will lead to improvement in sleep hygiene. Complete cessation of breathing apnea or partial decreases in breathing is called hypoapnea. So sleep apnea in demented patients in greater prevalence than in age-matched controls. So patients with dementia have a greater risk of sleep apnea, and they have more episodes of apnea. And as dementia progresses, the risk of apnea increases, and association with increased sleep disorder and apolipoprotein E, chronic hypoxia in Alzheimer's disease leads to increased beta secretase activity and production of beta amyloid protein. So treatment of obstructive sleep apnea in early stages of dementia may slow the progress of disease by modulating cholinergic activity that influences upper airway opening. Impaired cholinergic transmission leads to cholinergic respiratory disturbances. So donepezil will increase REM sleep when apnea episodes are more frequent. Donepezil is one of the medications that we use in patients with Alzheimer's disease dementia. One study showed that donepezil significantly improved apnea-hypopnea index and increased oxygen saturation levels. So longer sleep duration may be an early sign of dementia. Alzheimer's disease patients suffer from sleep disturbances, that include sleep fragmentation, longer periods on intra-sleep wakefulness, and this will also lead to problems for caregivers and patients as well. Community-based longitudinal studies showed that excessive daytime sleepiness was associated with a 2 times risk of incident dementia. As dementia progresses, the symptoms of poor sleep become more severe. Patients become sleepier during the daytime, and there is an increase in neurocognitive impairment, end organ dysfunction, chronic health condition, and increased mortality. So let's speak about REM sleep. REM sleep, dreaming inhibition of voluntary muscle activity. So the dreaming occurs during the REM sleep stage, and there is an inhibition of voluntary muscle activity, and this is to prevent the dreaming enactment during sleep. So REM sleep disorders include vigorous dreaming, enacting behavior, nightmares, and this is exacerbated by beta blockers, antidepressants, and neurological disease. So Lewy body dementia, it's 50 to 80%, and having a REM sleep disorder is one of the criteria that is used to diagnose Lewy body dementia. And patients with a REM sleep disorder or enactment disorder, they have an increased risk of developing Lewy body dementia in the future. A study in Finland done to evaluate prevalence and clinical characteristics and predictors of sleep disorder in elderly patients admitted to an acute geriatric ward found that a greater number of lost functions were significantly associated with sleep disorders, and that functional compromised elderly patients has a lower ability to react to adverse environmental stress factors, insinuating that the association between insomnia and impaired quality of life is more pronounced in older age groups. So irregular sleep activity pattern is a major source of difficulty for family members and caregivers. Institutionalized patients with sleep disruptions at night are more likely to exhibit aggressive behavior during the day. Any physical illness that causes the patient discomfort can affect sleep. As we discussed in the previous slides, poor sleep quality secondary to sleep disorders can have an effect on various chronic disorders. So let's move to pain and insomnia. One study showed that pain in 2 or more sites was independently associated with a 16 to 41% greater likelihood of having sleep difficulties. Persons with more severe pain had a more than 2 times likelihood of having trouble getting to sleep on 1 or more days per week than those with the lowest pain severity score. And there was a strong and consistent association between more severe and disseminated chronic pain and heterogeneous sleep complaints. Dysfunction of the hypothalamic pituitary adrenal axis has been found to be associated with increased risk of developing chronic widespread pain. Severity and distribution of pain was strongly associated with sleep disturbances. There was consistent association were not found between individual sites of pain and sleep difficulties. Diffuse distribution of pain is an important factor in the association between pain and sleep, and after adjustment for use of psychiatric meds and daily analgesics, the association between pain and sleep difficulties decreased modestly. A pilot study also suggested that better management of sleep can reduce pain in older adults with arthritis. Let's talk about the effect of music on sleep quality. So it's a non-pharmacological method to promote a mind-body interaction, and it's characterized by having no side effects, and it's multi-dimensional, touches physical and psychological. Each system of body has its own preferential rhythm. Loss of this rhythmicity can lead to anxiety, distress, and pain, and increase adrenaline, increasing the heart rate, respiratory rate, and pulse rate. Sedative music induces relaxation and distraction response and reduces pain and stress and anxiety. Let's move into the restless leg syndrome. There is a strong evidence emerging that it's modulated by presence of genes with autosomal dominant transmission and high penetrance. Reports significantly worse executive function in untreated restless leg syndrome patients than age-matched controls. There is little evidence to support drug treatment for suppression of periodic leg movements in the elderly. So, what are the symptoms and signs of restless leg syndrome? This includes creeping sensation in lower extremities, tingling, cramping, or even very painful sensations, usually in the lower extremities. There is an intense urge to move or massage legs, usually occurs when patients go to bed and cause sleep onset insomnia. So what are the comorbid conditions that are associated with restless leg syndrome? This include iron deficiency, renal failure, peripheral neuropathy, and also includes excessive caffeine intake. So especially iron deficiency has the strongest association with restless leg syndrome, and we should increase by ordering like serum iron studies, especially the serum ferritin. And if it's less than 75 nanograms per deciliter, we should supplement iron to these patients. Sometimes it works, even if they don't have anemia. So periodic leg movement disorder, it's characterized by subtle contractions of the muscle of the ankles and toes, impressive thrashing of the arms and legs, wake people from sleep, and there's repetitive continuous leg jerks every 20 to 40 seconds during sleep. 5 to 60% of the population is affected by this disorder, and the treatment includes benzodiazepines, Sinemet, dopamine agonists, opiates, and iron replacement as well. So there are certain issues that can lead to insomnia and that are specific to the geriatric population. These include menopause. Menopause is associated with prolonged sleep latency, decreased REM sleep, and decreased total sleep time. And menopause also plays a pivotal role in modulating both the presence and severity of obstructive sleep apnea by leading to progesterone and estrogen dysfunction. And progesterone is a respiratory stimulant. Estrogen affects body fat distribution. REM sleep behavior disorders. So this include loss of normal muscle atonia, which normally occur during REM sleep. So in REM sleep, the normal physiology is to lose muscle control or having a degree of muscle paralysis, and this is lost in patients who have REM sleep disorders. So persons with this disorder may display a variety of movements during REM sleep, including walking, thrashing limbs, or engaging in complex activity, and this is usually noticed by the bed partner. Let's speak about narcolepsy. Narcolepsy is excessive daytime, it leads to excessive daytime somnolence and fatigue. So it's characterized by sleep attacks that are irresistible. So there is also the hypnagogic hallucinations that occur when the patient is attempting to sleep. Also, it's characterized by sleep paralysis and sleep and cataplexy, which is a sudden hypotonia that develops in response to a stimulus like excitement or excessive fear. The Wisconsin Sleep Cohort Study, it demonstrated that a transition into menopause was associated with a significant increased likelihood of having obstructive sleep apnea independent of known confounding factors. In post-menopausal women, a functional or physiological difference rather than upper airway anatomy may account for observed differences in severity and prevalence of apnea between pre- and post-menopausal women. So this is a type of obstructive sleep apnea that develops as a result of menopause, and that's related to upper airway obstruction and the physical anatomical obstruction. It's related to hormonal disturbances that occurs in postmenopausal women. So what is sleep apnea and how it affects sleep? So sleep apnea is one of the most important causes of sleep disturbance, and it's frequently occurring in the elderly. It's characterized by repetitive upper airway obstruction, arousals, decrease in oxygen saturation, daytime sleepiness, snoring, and impairment of cognition. It's hard to establish a diagnosis due to the lack of normative data in the apnea hypoxic index. So let's speak about age-related respiratory physiology. So with age, there is decreased airway size and changes in elastin to collagen ratio that does not only occur in the airways, but also affecting other parts of the body, such as the skin. And there is also decreased elastic recoil of the lungs. So there is a decrease in elastin in general, affecting multiple body organs. Also decreased oxygen diffusion capacity and premature airway closure, causing decreased ventilatory to perfusion ratio or ventilation perfusion mismatch, and increased alveolar arterial oxygen gradient, also because of stiffening of the lungs. So the oxygen does not diffuse adequately into the arterial system, which eventually impairs the oxygenation of the blood and the oxygen that reaches the brain. A small airway closure with air trapping. Also, there is increased rigidity of thoracic cage, leading to more diaphragmatic and abdominal breathing, and also decreased vital capacity, increased residual volume and functional residual capacity, but a decreased vital capacity and inspiratory reserve volume. So changes in people with sleep apnea. So what happens in sleep apnea is that the upper airway becomes smaller in caliber due to the physical obstruction. Studies of upper airway found that upper airway dimensions decreases with age. So as age increases, there is a decrease in the upper airway dimensions, leading to a higher possibility of developing obstructive sleep apnea. And also the airway not only decreases in caliper, but it also tends to collapse easier. Also, there is increased deposition of parapharyngeal fat, increased pharyngeal collapsibility during sleep as well, and some contradiction when anatomy is studied. So the ability of the genioglossus muscle, which is the major pharyngeal dilator muscle, to respond to increase in pharyngeal negative pressure impairs in the elderly. So this slide summarizes that how physiological changes, normal physiological changes that occurs with age increases the risk of developing obstructive sleep apnea. So what are the lung volume changes? An increased lung volume can apply a caudal traction force on the trachea and larynx, inducing longitudinal tension on the upper airway reducing intraluminal pressure to close and reopen the airway and decrease pressure exerted on the airway walls by surrounding tissue. Studies have shown that increases in end expiratory lung volume can protect the upper airway from this collapse. So sleep apnea physiology, arousal threshold. One is aroused from sleep due to upper airway obstruction when ventilatory drive reaches the arousal threshold. This is an important protective mechanism. Hypothesized that older adults may have a lower arousal threshold, and this is controversial. A ventilatory control system, increased CO2, decreased oxygen, and suggestions that chemical control of breathing in the elderly may be unstable with increased proportion of central apnea and the elderly with sleep apnea, owing to the prevalence of periodic breathing and the elderly, especially those with congestive heart failure. This is also controversial. Consequences of obstructive sleep apnea, sleep disturbance disorders occur more frequently in patients with Alzheimer's disease than in non-demented elderly and increase with the degree of cognitive impairment. So neurocognitive excessive daytime sleepiness decreases the quality of life from sleep fragmentation, and some studies show that increased cognitive impairment, especially in older women. So metabolic dysfunction and cardiovascular disease from intermittent hypoxia and sympathetic stimulation. So what are the conditions that increase the risk of obstructive sleep apnea? This include hypothyroidism. It also include acromegaly, disease states affecting the upper airway, like tonsillar enlargement, for example. Obesity is the major causative factor for obstructive sleep apnea. Also, patients who have a thick neck, they have an increased risk, and measuring the neck circumference is one of the screening criteria when it comes to diagnosing obstructive sleep apnea. Also, crowded pharyngeal inlet and presence of retrognathia, which is an abnormal position of the jaw, and macrognathia as well. Let's speak about central sleep apnea. So there is a... Yes, Dr. Nader.
Can I just interrupt you for a second and
Of
can
course.
continue later? So I'd like to ask maybe after Dr. Amal is done with the topic, if we have 2 volunteers for the interview session. Dr. Ali will be participating as program director. So in the app or in the chat, maybe you can add your names. I just want to volunteers to act as a candidate for the interview mock session. Thank you. Continue, Dr. Amal. Thank you so much.
Thank you very much. So let's move to central sleep apnea. There is a pattern of respiration. It's called Tiny-Stokes respiration, which is characterized by waxing and the waning of breathing and apnea. How to treat that? So it's like a disorder of central, one of the disorders central disorders that can lead to sleep apnea. So treatment involves CPAP, weight loss, decrease alcohol intake, avoid supine positioning during sleep because gravity assists with diaphragmatic muscle movement, and of course avoiding benzodiazepines because it's one of the drugs that can affect the central respiratory drive. So let's speak about sleep heart study. It was a large epidemiological study. Prevalence of sleep disturbed breathing was with increased age. About 20% of subjects greater than age 60 had a respiratory distress index greater than 15 hours, even healthy non-obese. And asymptomatic for obstructive sleep apnea men affect more than women. So anatomically, decreased pharyngeal airway was a key factor for most and showed developed upper airway obstruction ability to maintain a patient airway. Amount of soft tissue located in the body compartment created by the mandible and spinal column, and the ability of strength of the pharyngeal dilator muscle to contract, the ability of the pharyngeal dilator muscles to respond to mechanical and chemical stimuli during sleep, changes in lung volume, and effect of ventilatory control stability. Aging may be associated with important changes in one or a combination of the above-mentioned factors. So elderly have a decreased, which is a substantial decrease in ventilatory response to hypercapnia and hypoxemia, possibly related to a physiological decline in the ability to interpret and integrate information from the peripheral and central chemoreceptors and from mechano receptors to generate an appropriate neuronal feedback response. So let's speak about the physiology and anatomy of sleep apnea in the elderly. So upper airway, there is a smaller caliber, and studies found that all upper airway dimensions decrease with age and collapse easier, and there is increased deposition of parapharyngeal fat and increased pharyngeal collapsibility during sleep. Some contraindications: decreased ability of genioglossus muscle to respond to increase in pharyngeal negative pressure is impaired in aging. So this is the major dilator muscle, and its function is impaired with aging, and this is one of the factors that leads to the development of upper airway narrowing in the elderly population. Let's go over some definitions. So apnea is defined as the complete cessation of breathing. Hypoapnea is the partial decrease in breathing. Sleep apnea in demented patients in greater prevalence than in age-matched controls. Apnea increases with severe dementia, as we mentioned in the previous slides. Also, sleep apnea is linked to hypertension, either as a causative factor or as an exacerbating factor for previously diagnosed hypertension. So CPAP, which is the continuous positive airway pressure, is the gold standard of treatment for obstructive sleep apnea. And it has good long-term compliance is difficult. How to treat obstructive sleep apnea? So CPAP is a symptomatic treatment. It's not curative. And also it's important to avoid substances that may worsen sleep apnea, like alcohol and sedating compounds and nicotine. Weight loss is very important in the management of obstructive sleep apnea because most of the cases are related to significant increase in weight. Even a moderate decrease can improve symptoms. And sleep position also is very important in the management. Patients should avoid lying in the supine position. Let's talk about a condition is called senile emphysema, which is a physiological change. So with age, there is increase in lung compliance resulting from airspace dilation and remodeling of the lung parenchyma. And this is, as we said earlier, is the result of decreased elastin to collagen ratio. Sleep apnea, decreased neurocognitive measures related to sleep apnea, decreased performance on measures of attention, concentration, and complex problem solving. So sleep apnea is associated with mood stability and depression. In Alzheimer's disease, sleep apnea could be a consequence of cell loss in the brainstem respiratory center and neuronal degradation in Alzheimer's disease could be hastened by nightly insults of intermittent cerebral hypoxemia related to sleep apnea. So sleep apnea and disturbed breathing have been associated with falls, decreased cognition, and increased institutionalization. How to evaluate sleep apnea? Examine intranasal nasoseptal deviation and the possibility of allergic rhinitis. US studies in persons over 65 using a questionnaire reporting snoring showed that 4% of older women and 13% of older men snore. How to treat this condition? By applying oral appliances, which can lead to repositioning of the mandible and improving the airway space at the hypopharyngeal level. Made and fit by dentists, may cause temporomandibular joint dysfunction, tooth and gum pain, proprioceptive malocclusion, impaired salivation and gum disease. Surgical approaches include uvuloplasto, pharyngoplasty, mandibular reconstruction, and genioglossus advancement. So some limited evidence indicates that the treatment of sleep apnea may reverse symptoms of dementia and sleep disturbance disorder should be included in the differential diagnosis of reversible dementia in older adults. Obesity, metabolic syndrome, and increased obstructive sleep apnea seem to be associated. Suggestions for a link between obstructive sleep apnea and hypertension hold for the middle age, but not elderly. There is a good evidence in the literature demonstrating that obstructive sleep apnea may worsen left ventricular function and the development of congestive heart failure. We know that sleep apnea affects the right ventricle more than it affects the left ventricle, but studies suggest that left ventricle with time can be affected as well, leading to biventricular failure and the development of congestive heart failure. So one study demonstrated that the presence of severe obstructive sleep apnea increased the risk of ischemic stroke in the elderly. Obstructive sleep apnea and central sleep apnea appears commonly in patients with congestive heart failure. So thank you so much for paying attention. I know that was a lengthy presentation. Thank you so much for listening. And now we're going to move to the next agenda, which is the mock interview. And please let me know if you have any questions regarding this topic on insomnia. Thank you very much, Dr. Nadir, for giving me this opportunity.
Thank you so much, Dr. Amal, and thank you, Dr. Saja, for great presentation, two of you. This is great. Thank you so much. So for the next item, I'm not sure if anyone added your name to the app, not yet. So I'll let Dr. Ali, maybe, if you are here, maybe you can give us some of your experience. Dr. Ali is a fellow who graduated from our program, and he successfully positioned in a residency program. He finished his, or he's finishing his residency next year, and he is going for a cardiology fellowship. So Dr. Ali, if you are here, please share your input.
Yes, good afternoon, everyone. Thanks, Dr. Nader, for having me. I really appreciate the chance of contributing to mentoring the currently applying applicants for this season of residency. Yeah, I thought I can try to interview one or two of you guys. I think I believe in teaching by example more than like talking about my thoughts or ideas. So if you could have any one of you uh, guys wish to, just be just a volunteer,
So
I can.
one thing I agree with Dr.
Mhm.
Ali is by practicing. And I just want to remind you one thing in the interview process, most of the program directors and faculty want you to know is that it's a process uh, like a conversation. So
Mm.
if you deal with it as a conversation, any one of you might jump in right now and talk to Dr. Ali, and he will act as a program director, and you will be like a candidate. And it's gonna be just a conversation.
Yeah.
It's not
Yes.
gonna be stressful if you look it that way. If you are looking as if it's questioning you and you have to come with answers and you are on spotlight, then it will be nerve attacking or just aggressive or
Yeah.
giving you anxiety.
Yes. Exactly. I agree 100%. They're not testing your knowledge or anything. There is no right and wrong answers. It's all about assessment of your general understanding of the program and your personality. How do you deal with questions? How do you deal with the stressful? There is no more stressful situation than being in an interview. So basically, they are not looking for your direct answer. They're looking rather about the way how you deal with the answer and how you behave during the interview. That's it. It's all about that. There is no a right or wrong answer. Your way of mitigating stress might be different totally from the way that I'm doing it. And it's a very subjective thing. The most important part is you should be uh, behaving professionally, and you should be demonstrating interest into answering questions, and your answers should all be consistent with your CV. It should be personalized according to whatever you have written in your uh, resume. So that's basically the core idea of the interview. Otherwise, it doesn't matter exactly the information you are giving in during the interview. Other way
So
of doing it, you can just yeah.
maybe Dr. Ali, maybe you can give us just a snippet from your last interview. So Dr. Ali is currently applying for fellowship. He is going through 3 interviews, I think, at least, and
Yes.
he already did one. So why don't you share with us your last experience with the interview and doing the fellowship, like you are applying for fellowship. What
Yes,
happened?
sure. Yeah. So they're gonna send you the invitation, whether through an email or through ERAS, a communication system, or through Thalamus, whatever program they're using. Initial invitation, that's like you have been selected to interview with us, and then subsequently in few days or so they're going to send you a detailed schedule of the interview, like the timing. Of course, they some programs give options. You have the option to choose between different timings availabilities. Some programs give you the date, like we are interviewing candidates on that day, and then they will let you know who's the faculty members you are interviewing with, the duration of the interview, and most of the details regarding the interview day. And now most of the interviews are just virtual. Back in days it used to be in person. You have to come personally to the facility, meet with everybody and everything, but now it's just kind of 99% of programs. I think just very few programs are still using in-person interviews, but now most of the 99%, I would say, of programs are just interviewing virtually. So usually the interview starts by general introductory talk, which is usually held by either the program director or one of the chief residents. It's like meeting with all applicants in the panel, just giving them like kind of overview picture about the program values and missions and the training process, rotations and electives and everything. And then you're going to be split it up into panels. Like each group of applicants will be interviewing with particular group of attending physicians or like faculty members of the program committee. So the residence interview used to be a little longer and a little detailed. Like you're gonna meet with everybody in the program faculty, the program director, the associate director, and one or two of the faculty members. But in the fellowship now, we are just meeting with either like one or two attendings from the faculty. But for you guys, you are applying for residency. I think you should better be prepared to meet with everybody. So the program director would likely meet you the first one. They would like try to break the ice, make you feel calm. They start by like just thanks you for applying to our program. We are pleased to have you here. And then the first question is always, may I know more about you, or introduce, how to introduce yourself, or tell me more about you. Whatever phrase they are going to use, the idea is same. They just want kind of introductory talk to the interview. You should be 100% prepared to answer this question. It's always the first question. No matter which program, which specialty, which level of training, always the first question in a job interview in the United States is introduce yourself or tell me more about yourself. You should be practicing this question at least 100 times before you step on the actual deal. It's still like mid-September, so you still have enough time before interviews starts. You should be practicing this on daily basis for the upcoming remaining days prior to starting the interview season. By the time you are getting into your first interview, you should be 100% confident into answering this question. There is no room for like just saying something out of the blue or like trying to memorize things during the interview time. It's going to be very obvious and it will give very bad impression. This might be the only question that need you to be 100% prepared, because it's like it's a known question. It's kind of generic question for all applicants. So at least this one you should be prepared for it. Your answer should be very simple, very short and straight to the point, but at the same time very impressive. It should be giving impression, like the first impression should be a huge dose of confidence and something very personalized about you, highlighting your skills, experiences, and what is peculiar about you, something that would really impress the program director. You don't necessarily need to mention anything that's mentioned in details on your CV. You don't go into details. You don't be like repetitive or redundant. It's not recommended to talk about where you have been living and where you were born, and unless it's something really unique. Like if you were born in like something that might be very unique, very peculiar about you, it might be worth mentioning. That might drag attention of the interviewer. But otherwise, do not waste a lot of time, because it's just 1 or 2 minutes, not more than that. If you continue to talk for more than that, that means you're going to take time from the other questions, which is going to be also against you. You need to keep your answer simple, because you need to spare enough time for the interviewer to ask you all the questions he have. By the end of the interview, they will be counting questions that they have asked you. It's always in your best interest to be exposed to like as many questions as you can. If you spend the whole interview time answering just 2 or 3 questions before the time ends, that's not a good thing. It gives impression that you're not prepared enough. you're not confident enough. If you know exactly what you are talking about, you should be able to express yourself in very simple words, very straightforward statements. So just start by thanks for having me, or like thank you for inviting me, or it's my pleasure to interview here. I mean, something that would show that you are very thankful to them. And then just highlight very frankly, like very obviously, your skill, your experiences, uh, and then something special about you, something very peculiar about you that might like make them more interested into listening more to you. And then your interest in the program. That should be like the opening statement. Your first answer should be like that. And then rest of questions are variable. It's not like it's standardized for all programs. But there's like this list of questions that's roaming on social media. You can find it everywhere. It's like more or less kind of the same thing. um, why did you choose the specialty? Why did you choose our program? What are your greatest strengths? What are your greatest weaknesses? How do you deal with the stress? How do you deal with a difficult uh, situation in the workplace, like a difficult patient, difficult co-patient, difficult co-worker? How do you mitigate um, conflicts of um, I mean perspectives during the workflow? Those are kind of a standardized questions for all applicants that expect them to be at some point during the interviews. And then they will come to ask you particular questions about you yourself, something that you have mentioned in your CV or your personal statement or your letters of recommendation. So here it comes the importance of knowing your CV very well in and out. You cannot just write something in your CV without being able to answer any question about it. If you have written that I have had an observership for 2 months in University of Colorado, for example, or anything, you should expect that they might ask you questions about this. They may ask you what you have been doing in that observership, what were your responsibilities, and how did you get that observership, and what difficulties you have met through that observership, and what kind of learning points you made up through that observership. And then now, even the geriatric fellowship that we are doing now, just be very prepared to answer all questions that you might be asked about. They're going to ask you, and I have personally been asked about it both during my residency interview and currently during my fellowship interviews as well. They're going to ask you about it. What's the idea of the program? What's the mission of the program? And what made you choose to do this fellowship training? And what are the learning points or the experiences that you have gained after contributing to this fellowship? And then they're going to ask you about your research publications, if you have had any publications during the fellowship, your research presentations. They may just ask you generally what kind of research you have presented or published after like joining the fellowship, or they might go even too deep and starting asking you about a research that you have placed on your eras, like under the research title, um, whatever paper you have written as published or presented, just be ready to answer questions about it. They may ask you about the method, the the group that have contributed to the proposal, the abstract, where you have presented it. And they may even ask you about the findings and the conclusion, if it has been like something interesting to the interviewer. So be ready to answer all those questions, whether they ask you about the research fellowship itself, as like in a matter of like experience that you have gained, or if they ask you about any one of the research or publication that you have contributed to. If there is more time, they may go and ask you about some personal stuff in your personal statement. like your personality, your hobbies, your values. What do you want to do after residency? That's also a common question. They need to see you, like they need to know exactly. It's not like you just here for 3 years and then you are gone. Because after graduating from residency, you're going to be ambassador of that institute that you have trained in. They want to make sure that after residency, you have a plan of doing something that might bring excellent reputation for them as a residency program. So it's like I said to you, it's not like there is a good answer or bad answer or right or wrong answer. Your answers should just be authentic, valid. You should be honest, and there should be an integrity in the answer. And then read about the program and try to tailor your answers according to the program needs. If you got an invitation from a community program, that's basically a kind of community service in a program or like medical center. They are basically a non-for-profit organization that's just established for helping communities. They would be more interested to listen about like being a clinician, being in a community, attending community hospitalist, something like that. Somebody who is willing to pay back for the community that he has been trained to serve for 3 years or something. But if you have been invited to interview at a very big university institute, then they expect you to be an academic, like teaching kind of physicians who wants to join a academic program and continue to teach medical students and residents and fellows and stuff like that. If you joined a big research center, then they expect you to be a researcher. They need you to talk more about your research interests, what kind of research projects you are like interested in, like systematic reviews, meta-analysis, whatever, experimental studies, whatever. But you should be able, your answer should be tailored according to their needs in order to get their attention. If you work for like a VA, for example, there are some programs sponsored by VAs like veterans services. You should also talk about paying back to those people who have been like serving this country for years and years. And yeah, that's it. Your answer, you should know exactly where you are interviewing, and your answer should be tailored to that thing. And then finally, they may ask you, what questions do you have if you still have time? The problem is that when time comes for this, you're gonna be like, most of the things would be answered. You're gonna know everything in and out, which is kind of tricky situation. You can never say that I don't have any question. I know everything, because it's either you really know everything, which is very unlikely, or you are uninterested in the breast. So you should always have a question that's not available on the website, that's not answered during the interview, and that's not repetitive kind of thing. Um, like most of the applicants ask the same questions back and back again and again, like um, what kind of elective rotations do you have, what kind of like scholarly activities or research activities, which is going to be also a little funny because it's like kind of a common question. They need something different. I will leave it up to you. The question should be something that's peculiar about the program, but like I said to you, it shouldn't be something that's like largely abused already, like questions that have been asked for many years. Try to find something different, something that's not easily foundable on the website of the program page, or like something that you haven't they also don't want to, like, you don't want to give them impression that you haven't been paying good attention during the introductory lecture or during the interview process. Yeah, and then thanks for having me. Bye bye. Send them an email, thank you email or thank you letter after the interview, maybe the next day or the same day, late in the day. that you like the interview and it has been a pleasure meeting with them, and then like giving a hint that you are ranking them. And be honest, if you are not actually ranking them high, because programs do communicate with each other. If you have a connection to the program, like if you have somebody who talked to the program about you, it might be worth ranking the program high, because it's really it's unethical for like to get interview spot for a program that you are already not interested in. But I mean, it's up to you guys. This is something that you better evaluate it. But generally speaking, be honest, and if you are really ranking the program high, that would be obvious during the interview. You're going to appear so passionate, so enthusiastic, and they can really smell that very easily. They are so expert into finding out who is interested and who is not. Yeah, I think that's pretty much kind of highlighting things. I know that there are a lot of things that I can talk into details about them, but I don't think that time is enough for today. But I'm very happy to practice with you guys. If you want, like upcoming weekends, we can like set up 1 or 2 sessions to practice. I also want to practice. That's also be good for me, and it will definitely be a good experience for you. If you have any question today, I will be happy to answer. If you are kind of satisfied with the talk, then we can conclude up and try to arrange for another day, maybe next weekend or the weekend after, to like set up 1 or 2 interviews. So some volunteers from the group here.
Sounds good. Thank you so much, Dr. Ali, for great tips. Any questions for Dr. Ali specific? I think one of the fellows here asked about community programs. Can you raise your hand or can you jump in and ask the specific question? Let me see who did that. Haifa, Dr. Haifa, are you still there?
Question regarding community hospitals. Are they identified as a community hospital on the list? I'm not sure if this would be mentioned on the ERAS, but it would definitely be mentioned on their website. So the best place to find more information about every program is from their website. Just visit the website, read it from A to Z, in and out, listen to every podcast they do have, watch every videos they do have, and read all the articles and the program director message and everything that they have posted on social media, on LinkedIn, on YouTube, on Facebook, and every platform that they have a page on. Just visit it, and definitely you can figure out exactly if they are like more kinds of community programs, or they are like kind of more inclined to being academic or teaching program.
Thank you so much, Dr. Ali. I just want to add that on Residency Explorer, there is a section where it mentions whether the program is a community hospital, university affiliated, or a university program. So it's clearly mentioned on Residency Explorer.
That's correct. Yeah, I remember that. There is also this there is a website, I forgot its name. It's called something like Residency Explorer. I forgot its name, but it's
Frida, I think.
Preda. Yep, Preda. Yeah, it also has some information about programs.
Go ahead, Dr. Jafar.
Yes, thank you so much, Dr. Ali, for your tips. You said at the end of each interview, we should ask a question about the program. Can I ask a question about the city, about living in the city, about the housing, the rents, something like that, or it should be
I
strictly to
don't
the program?
recommend that. I don't recommend it for 2 reasons. First, it's better to find information about the city from the city website. Every city in the United States have their website, and they have Facebook page, YouTube channel. It's better to find more information about anything outside of the workplace from like other kind of locations. It's not something that the program would give you best answers for it. That's one thing. The other thing is that I don't know, it might give them an impression that you are more kind of looking for something else more than the work environment or more than the training values or missions. I don't know. This is my perspective. Again, it's something that's very subjective. You might find some people would give you different answers. But from my perspective, I would be more appreciative if my applicant has asked me something about my programs. You got my point? Because the city is not in my control, right? The city and the environment and the weather and the temperature and the culture outside, the people. This is not something that I can help with. Whether the city is good or bad, or the weather is, favorable or not, that's not something that we can help with. The thing that we can help with, or it might show that you have interest, is something that we have created, like mentoring sessions, elective rotations, international elective rotations, skill labs, something like this, something that the program would provide for the residents. But some people also ask about the benefits and the earnings, like the salary, the compensations, the health insurance. And again, those are not, I don't recommend this. It's kind of a training job more than a service job. And it's just for 3 years. So it's a temporal training job. You're not expected to earn a lot. You're not expected to have much of benefits or to have like much of comfort with the city or the culture of the people there or the community. You might like put it just at the margin of your interview that you have. You have got to know that the city is rich in so and so and so, and the weather is like so and so, but you don't make it like the cornerstone of your interview. You got my point?
Yes, thank you so much, Dr. Ali. Thank you.
You're welcome.
Go ahead, Dr. Ala.
Thank you, Dr. Nader and Dr. Ali.
Mhm.
I was wondering if it's okay to ask about the work culture and the environment and what is expected from us as residents. Would that be okay to ask during the interview?
I personally again, I don't find it as the best thing to ask. Only if you like run out of all ideas. Now, guys, I talked to you at this time, like a month or so prior to starting the interview session. So you could have enough time to brainstorm new ideas. All those ideas have been already consumed. The benefits, the earnings, the city, the culture, the weather, the work environment, the what do you expect from me, what do you think the good resident is, and all those questions have been asked thoroughly previously. You're not bringing anything new to the table. So you still have enough time, more than enough time actually. Instead of just like rehearsing the same thing or recalling the same questions and answers for the rest of the time, use this time that you still have prior to starting the interview season in order to come up with new ideas. You still have enough time to come up with very new ideas. All of those ideas have been asked previously. You're not bringing anything new. And I'm pretty sure that the interviewer, the program director, or whoever is interviewing you has heard similar questions hundreds, millions of times before that. And by that, I don't mean like it's wrong to answer them, but you're not bringing anything new. You might not be like having penalty for this, of having bad like impression asking those questions, but you're not getting credit. You're not making yourself standing out of the group, right? So I don't know, if you don't have anything new to ask, like if you couldn't find any other new ideas, you can just go ahead and ask the same question. But it's a weak question, to be very honest. and most importantly, it has been consumed previously. So ask something that's particular about the program where you're interviewing. That's like read the program page. Some programs have a booklet, a very detailed booklet. Some of the programs that I have interviewing in now, they have like kind of 200, 300, 400 pages, booklets on their website. Download them, bring them and read them. Definitely you're going to find something that's peculiar about that program. Whether they have some program that I have interviewing, it have like kind of a side parallel PhD program that you can do during the MD program. They have side parallel like something like diplomas in ultrasound scanning. They have like some certifications in leadership, public health, master of public health, master of business administration, master of healthcare administration. So some programs have kind of like particular stuff that's unique for them. I think this is where the money is. This is where you should be tailoring your questions to. It will make you very like looking up, like as very interested person. You have looked up the website thoroughly. You have like being very detailed, like very aware of everything in the program. You have very good knowledge of the program structure and the service that they're providing, and you're not repeating yourself. You're not repeating other people's ideas. Does that make sense?
Yes, it makes a lot of sense. Got you. So the mission is to impress them, more to know about them. Is that what I get from you?
Exactly. It's not like you are just giving robotic answers or robotic. You're asking robotic questions. You got me?
Got you. To be unique and impressive, so they can choose you. Got you. Got you.
Exactly.
Thank you very much, Shukran.
Yeah, and to appear like you have already studied them very thoroughly. Yeah, but asking something like, "What do you expect from me?" I mean, they expect everything from you, right?
Yeah, sure.
They expect you to be like knowledgeable, skillful, professional, ethical, integral, honest, and everything, right? That's like kind of a very broad question, and the answer would be something that's not easily answerable in a minute or so, right?
Yes, yes.
Yeah.
Okay. Thank you very much.
Yep. I'd like to thank you so much, Dr. Ali, and thanks for the question. I'd like to add, if you look at it, maybe you can prepare a couple of questions, and it depends on the level of who's asking. If it's sometimes you spend some time with residents or chief resident. So the question just you mentioned or someone mentioned about the environment and how is the training and so forth might be applicable for the level that you're talking about. In the past, it used to have like they invite you one night before the actual interviews, and you get to know the residents, how is their life and the city and so forth. But that question or this question might be at that level in general. But I think you should prepare some questions for the faculty or the attending, and some questions might be directed to the program director specifically. And as Dr. Ali mentioned, you should study the program from their websites. If you have contacts, you can talk to the contacts, YouTube videos, and sometimes you need to identify some of the areas that they excel. And by doing that, you can identify that there are other areas that they may not be as good in. So when you want to ask some question, I think you can separate it into 2 or 3 sections. Your question is supposed to, the first part is the introduction part for the question. So you don't ask the question the same way one of you just asked, tell me more about this or that. I think it's better to give a background or an introduction to your question. So you can say, I reviewed your website, or I looked at your information on YouTube, and I found that you have a very good board passing score in your residence or something like that. So you tell them that what you found positive about their program. That lead you to the second part of the question, and you can ask your part of the question about, let's say, do they offer review questions like mix-up questions? Do they go to board review courses? Or maybe you can ask about fellowship programs. How is their successful rate in achieving further training, like in other fellowship, subspecialty fellowship program? So that might be the second part of the question. And the third part might be to highlight why you ask that question. Maybe you can highlight some interest. So I ask this question because I'm interested in pursuing GI fellowship after the internal medicine fellowship, something that tells them something about you and its opportunity for you to shine some part. So with these three parts of the question, you already showed them that you are interested in their program. You already studied their program, you obtained some information, and then you ask the right question if this is really what you want to know more about. And along with that, you added some value or something from your personal experience or interest. Or it can be something that you thank them for. So I really appreciate you answering this question. So it's an opportunity to thank them again if they are available to answer question. And if they ask you any more question, you can ask the second question with the same way. The first part about what part of the program you are interested or you gained information about. So something like that. And so these are some of the tricks. Some of it might be also when you answer their questions, when they ask you about something, you don't answer right or like yes or no, short answers. You divide your answer into parts. So the answer part of the answer that's addressing the question, you can put that. But along with that, you train yourself to lead them or give them a bit about something that you want them to talk about, let's say about this fellowship program. So if they ask you about something, you can add that my experience with that to answer the question, and you add something also in this program, telegeriatric. I was a leader or I was involved in doing so. So by that, you open the door for them so that you can speak more if they ask you more about this program or about any part of your CV that you are interested in talking more. So there are tricks of doing that. Thank you so much. Any other questions?
Yes, I 100% agree with you, Dr. Nader. Uh, and remember, guys, you just need to sell yourself. It's kind of commercial thing here also. You need to appear very sharp, very enthusiastic, very motivated to work. By the end of the interview, they should have the feeling that you are a strong asset to them. Like you're gonna add something to that program. Either you're gonna help the program because they are also waiting for some benefit from this relationship, right? It's not like one directional relationship. As you are you want to get trained appropriately and you want to get licensed being an American trained, like physician trained in America. They also need something from you. They need to promote the program. They need to have graduates who have like either very good in knowledge or skills or like research or volunteer work or presentation skills. They need to get a benefit out of you on the top of seeing patients, of course. Of course you're going to see patients, you're going to help in like treating a lot of patients during the 3 years of training. But that's something that everybody can do. They need something that you only can do for them. You're going to achieve, for example, the best research publication in the program, or you're going to be the best presenter, or you're going to score the highest score in the board exam after the training, or you're going to be ending up being in a very prestigious fellowship program in a very noble university program. By that, they're going to hire you because you're going to be a strong asset. You're going to be a positive thing for the program. You're going to be a good thing for the reputation of the program. But if you're going to just come, finish 3 years of training, and then leave without adding anything to the program, that would also be fine, but it would just put you in the competition with everybody, like 95% of applicants. 95% confidence interval. 95% of applicants are going to be competing for this spot, like just an average resident who's just barely able to see patients, treat them, and go home. That's going to be tough for you. You can still get the spot, but it will be, so competitive. But if you could be able to advertise yourself, to commercialize yourself in a way that would make you appear as very peculiar person, something that like somebody who would be very special to them, who would add something to the program, would either take good care of the schedules, who has very good leadership skills, who would be a very good chief resident, who would be a very good researcher, who would be an excellent communicator, who would be an outstanding presenter, an outstanding researcher, who would be a very good exam taker, who would be a very high scorer. You got my point? All those things are very important points that the program is actually looking for to promote their program. As we are competing together, they are also competing together. Like as we as physicians compete together with each other in order to end up in very good programs, programs are competing with each other. They also have their annual evaluations by ACGME, which is like kind of the medical council who is responsible for training physicians in US. And all those societies, American College of Physicians, American Society of Cardiology, American, like all those kind of institutes, they're acting as supervisors or monitors for the program performance. They're looking for graduates, their performance, even like after years after graduation. They're looking for their graduates' success rate in the American board exam. They're looking for their research profile, their scholarly activities, their presentation skills, and everything. So once you get into the program, you need to add something to that program. That's how they're looking for you. They're not exactly looking for a smart person who is like just good at treating patients, because most of the decisions are being made by attending physicians. Like during training, you need to be good team worker more than a good decision maker. You need to be good decision maker, of course, but a good team worker would be more valuable for the training program more than like a very smart person who has like 270s, 280s, but they're not very good team members. They're lacking leadership skills. They're lacking like research skills, or like you got my point, right? It's kind of like multiple criterions they are looking for rather than what's just single thing. As long as you are able to commercialize yourself, or more as you are able to integrate all those things together and advertise yourself in an attractive way, you're going to be ranked higher and higher, like more than the other applicants.
Thank you, Dr. Ali. And one question I thought about, maybe it can apply to most of you or some of you. You can ask about the position of chief resident. So, and you can put the question the same way, introduction and then the body part, and why you asked that question. So maybe you want to show your leadership. So you want to ask about the chief resident position, ask about how they select that position and what are the requirements for something like that. So from get-go, if they accept you, they may consider you for that position in 3 years. you got what Dr. Ali was just mentioning. You put yourself in a unique position, and by doing that, you help them identify who might be helpful in 3 years for the program to add some benefit to the program. So if your question is something that you want to get some information for yourself, but at the same time, you sell yourself with that question and you obtain the knowledge so that you can improve and achieve a goal that can benefit you and can benefit them in the future, that might be also very helpful. So just a thought to share with
Exactly.
you.
Yes,
Thank you.
exactly. And if you have exercised leadership at any point in your career before applying to fellowship, you should mention that in your CV and in your interview. Even if you have been a chief medical student in your medical college, or you have been even a chief student in your secondary school or primary school, or you have been a leader of the research team here in the geriatric fellowship, or you have been a chief medical officer in any remote health center in the middle of nowhere. This is the huge opportunity to mention this. This is going to be a very good point, a very strong point in your CV and in your interview, and this will make you stand out of the crowd. So do not be shy to mention those things. I mean, do not underestimate being a leader in a classroom or in a research group or in like a very remote health center in everywhere, or like being a leader in like subgroup rounds in the hospital, back in medical school, or whatever thing you have done leadership. Just mention it and highlight it. This is going to make you, and like magnify it. Those things might be very simple for you, but for them it's like as you magnify it more, as you like bring it in a way that like you are able to tell how you exercise the leadership and what kind of experience you get from that, and how was it very valuable as a leadership opportunity, and how it added to your leadership skills. It's gonna, make you stand out of the crowd, would make you distinguished from other applicants. So even now in the research fellowship that you are doing now, if you are a team member, or you have ever been a team member at any point during the last 6 months or the last year, mention it, be aware of it and mention it and highlight it, that you have been the team leader and you have arranged the lectures and the meetings of the group, and you have provided support and mentorship to your colleagues, and you have helped all of them achieve their potential. You have helped all of them present their data, and you have helped them and support them to publish their abstracts, and all of things would add a lot. That means you are willing to help your colleagues when you become a resident in the program. And that means you're going to spare much of the time of the program director and the associate directors to deal with other problems. And they can let you help like a lot with your juniors and colleagues. And yeah, you got my point?
Hello, Dr.
Yep.
Ali, can you hear me?
Yes.
I just want to ask, you mean highlight it in my CV, right?
Yes.
Okay. Thank you.
Both in your CV and in your interview. In your
Yeah,
CV,
surely.
in ERAS, you have this like 10 experiences, right?
Yeah.
Yeah. In each experience, you mention that the address or the title, and then underneath there is a space to elaborate more about the experience, right? This is your chance to mention that I have been doing a 1-year research fellowship in geriatric medicine in Michigan State University. And during that opportunity, I have gathered a lot of foundational knowledge and research methodology, and I have had a chance to be a group leader in the research fellowship, and I have provided support and mentorship to my colleagues and to my fellows. We have been a group worker together, and I have had a lot of experience in a group work, and we ended up publishing systematic review and so on, so on, so on. We have had the chance of publishing it in Journal of American College, for example, and I had the peculiar chance of presenting it orally or like poster presentation or whatever. You got my point?
Yeah,
But
perfect. I got it.
yeah, this will make you appear like you are a good team leader, you're a good team member, team worker, and you have exercised the leadership, babe. And it was successful experience because you ended up publishing something, right?
Yeah.
Yeah, that's a
All
proof
right.
that
Thank you.
you have succeeded as a team leader. Yep, you're welcome.
Right, thanks.
Any other questions? If not, I'd like to thank you so much, Dr. Ali, for all these tips and tricks. Thank you so much for your information.
It's
Thank you
my
for the
pleasure.
questions as well.
Yep, thanks. My
The
pleasure.
last part is update, any project updates and any updates in general. I'd like to announce that Dr. Isra has been accepted to NIH fellowship program. So I just found this morning. Congratulations, Dr. Isra. Dr. Amal, I'd like to add any of the fellows. Thank you.
So on behalf of all the presenters today, we would like to thank you very much, Dr. Nader, for giving us this great opportunity. And I would like to thank Dr. Ali for the great tips on how to navigate the interview season. And I wish you all the best for all match applicants.
Thank you, everyone. And with that, we can conclude our meeting. Thank you all for attending. Thank you, the presenters. Thank you, Dr. Amal. Thank you, Dr. Ali, for very informative session. We'll see you next week. Have a wonderful day and night. Assalamu alaikum. في أمان الله.
وعليكم السلام. Thank you, Dr. Nader.